So I would start off by saying welcome to everyone and a good afternoon. My name is Dr. Oge Ilebune, and we're welcoming you to the 14th webinar organized by Lakeshore Cancer Center. We have an unusual topic this time, which we've named a bird's eye view of an oncology tumor board, just to give a bit of snippets of what actually happens when different specialists come in together to discuss cases and arrive at good decisions around the patient's management and care. So we have a number of specialists on with us today, but we're also going to clearly invite questions and comments from the audience as well. It's been a pleasure to run these webinars, and each time we try to do something different that everyone learns from, including us as well. Just a few bits around etiquette. Please mute yourself as soon as you're in the room, but feel free to have your videos on. There will be questions at the end of every case study, but Professor Chuminwogu and Dr. Iwuji will be moderating the questions as well. You can either raise your hand or write in the chat. And then at the very end, there'll be opportunity for more questions before we round up. So I'm going to be handing over to Dr. Iwuji, who's the Lakeshore medical oncologist, and she'll take it from here. Thank you.
Okay, can you all hear me all right?
Yes, we can.
Okay.
Yes, we can.
Excellent. So good afternoon, everybody. As Dr. Oge said, my name is Dr. Chinenye Iwuji. I'm the medical oncologist at Lakeshore Cancer Center. And it is my pleasure to welcome you all and for us to discuss this topic, actually, because it's a very, very important topic. So we're talking about a bird's eye view of an oncology tumor board. And the first question is that, what is a tumor board and why is it so important? So in the US, they call them tumor boards. In the UK, we tend to call them multidisciplinary team meetings. And in the multidisciplinary team meeting or tumor board, the whole goal of this is for us to discuss our patients' cases. So particularly cancer patients in this setting, but it can be done in other specialties as well. So for our cancer patients, we want to bring their cases to a meeting where different specialists will be able to look through their investigations and plan the best outcome for these patients. So typically, our tumor board would consist of the oncologists. In Nigeria, we have clinical oncologists. In other parts of the world, they might have both the medical oncologist and the radiation oncologist present at the tumor board. You would have the surgeons there. You would have the radiology consultants, and you'll have the pathologists as well. Those are the core members of the tumor board, and all of them are very important because you need the radiologist to be able, the radiology consultant to be able to show the images so that the rest of the team can assess what's going on with the patients. And you equally need the pathologist to go through the histology slides so that the rest of the team, the surgeons, can decide whether surgery is appropriate, or the oncologist can decide whether chemotherapy or radiotherapy is the appropriate type of treatment. In other tumor boards or in other parts of the world, you can have additional members to the tumor board. So when I was in the UK, we would have nurse specialists there as well. We would have the dietitians there, and we can sometimes have palliative care consultants as well. So any members of the team, the healthcare team, that would be involved in the patient's care and that the patient might get referred to as well, they are key members of the tumor board. And the aim of the tumor board is to ensure that we give the patient the best outcome. And it's been found that we do get improved outcomes for patients when they're discussed in the tumor board because we get a more holistic view and different specialists giving their opinion for the patients. And this ends up with better patient outcomes. It's also a very educational meeting so that we can make sure that we are treating our patients according to evidence-based medicine and staying on top of the latest guidelines for these patients. As well as that, it's very good for networking as different consultants are coming from different parts of the hospital. It's good for us to meet each other, to get to know the different styles of working that we might have. And also, it also streamlines the referral process. So if you've already discussed the patient in the tumor board with the consultants that will be involved in their care, if as an oncologist, I'm now trying to refer my patients to Prof. Mugu, who's a surgeon, he already knows the patient's case. And so he's already aware of what's going on. Or if I need Dr. Anisike to give a second opinion on the patient's imaging, We've already discussed this in the meeting, so it makes the whole process more streamlined and efficient. So overall, the tumor board is an excellent tool that has been helpful in optimizing patient care. You can have different models of tumor boards. And in fact, myself and Prof. Mugu were discussing this recently. In the UK, the guidelines are that every cancer patient should be discussed in a tumor board. So every single patient that gets diagnosed goes through the tumor board and is discussed so that they can then be referred to the appropriate specialty based on the recommendations of the tumor board. In the US, for example, they tend to have more difficult, complex cases discussed at the tumor board. So it's not every single patient, but it's the patients that might be a bit more complex in terms of their management plans that are discussed. So different tumor boards have different goals. And based on that, you can then decide how your tumor board would be run. So in our discussion today, we're going to have a panel of specialists to sort of represent the tumor boards that we would have here. And so we're going to have a couple of cases, one prostate cancer case and one breast cancer case, just so that we can have discussions through these patients' care and investigations and use this as an opportunity to demonstrate what tumor boards run like. There are different specialists here, and I'm just going to briefly introduce everybody. We'll have Professor Mogu, who will be leading the tumor, Dr. Chimwe Mogu, sorry, Dr. Chimwe Mogu and Prof. Mogu, who will be leading the tumor board. He's a thoracic surgical oncologist and a cancer epidemiologist. So he will be leading the tumor board. I will be there as a medical oncologist. We'll also have Dr. Olubukola Ayodele, who is a medical oncologist as well from the UK. We'll have Dr. Chinedum Anasike, who is our radiology consultant, also based in the UK. We have Dr. Fred Obiajulu, who is a pathologist here in Nigeria, who will be contributing to the discussions. We hope to have Professor Frank Chinegundu, who is a urological surgeon based in the UK. We'll also have Dr. Alexandra and Professor Alexander Olawaye, who is a professor of gynecological oncology in the US. We'll have Dr. Jimo, who is our clinical and radiation oncologist based here in Nigeria. Dr. Chidi Awakuru, who's also a clinical and radiation oncologist in Nigeria. And also Dr. Juliette Lumati, who's a surgical oncologist based in the UK. The cases will be presented by Dr. Ebuka Onora and Dr. Zelu, that's not his full name, Dr. Zelu, who is one of our medical officers here at Lakeshore. Okay, so without further ado, I think we should go ahead with the presentation of the cases. Thank you. So Dr. Ebuka, are you ready to share your screen? Oh, yeah, Dr. Ebuka, if you can share your screen so you can present the cases, and then Dr. Prof. Mogu will be moderating the MDT.
If I may ask, thank you so much, Dr. Iwuji, for that introduction and summary. I know that for our prostate cancer case, Professor Chinegwundo was going to participate. I am right now not seeing him in the list of names. So I was wondering whether we should do the breast cancer case first. I know it's a little bit of an alteration in our sequence, but oftentimes that's what we do. You know, we're flexible and nimble.
That is fine. Is Dr. Zelu on the call now? Yes, there he is.
Yes,
Dr. Zelu, are you able to go ahead with the breast cancer case first?
If you're speaking, Dr. Zelu, you are muted. You might want to unmute yourself and then proceed. Yes. And who is sharing the PowerPoint? Okay, thank you very much. Excellent. Okay, Dr. Zelu, go ahead, please.
I think there might be a problem with Dr. Zelu's sound.
Dr. Zelu, are you there?
Can you hear me?
Now we can.
Okay. So I said I'm presenting OF, who is a 47-year-old female with a histological diagnosis of invasive ductal carcinoma of the left breast, PR positive, HER2 positive. So she noticed a left breast lump in February 2023, for which she was investigated for. She had a core needle biopsy done, and she was diagnosed with invasive ductal carcinoma of the left breast. Further immunohistochemistry testing revealed a PR positive, HER2 positive breast cancer, which came out to be a triple positive breast cancer. So she was requested to do an MRI of the breast, which revealed 2 lesions measuring 2.5 and 1.8 cm in the upper outer quadrant of the left breast, with 2 indeterminate lesions seen in the posterior third of the upper outer quadrant, with no axillary lymphadenopathy bilaterally. So we presented her pathology reports and the MRI images at our MDT meetings in May 2023. And the consensus at the time was to commence her on neoadjuvant treatment with surgery afterwards. So the neoadjuvant treatment consisted of 12 cycles of weekly paclitaxel and 4 cycles of 3 weekly anti-HER2 treatments, which included pertuzumab and trastuzumab. So she had those cycles with us, and then we asked her to do a repeat MRI for a mid-cycle review, which we'll be comparing with the pre-chemo MRI breast that she did earlier in April. So Dr. Anosike will be helping us with the imaging review, and we'll be presenting her today to determine the next line of management to see how far she has progressed since starting treatment.
Okay, thank you very much.
Okay, good afternoon, everyone. So for starters, the patient had, I'm just going to share my screen to show you the patient's scan. So the first scan that was done by the patient was available. The first MRI scan she did was not available. That's the pre-treatment scan. So what we have is a post-treatment scan. It's a breast MRI, so I've taken this axial.
I'm not seeing it. Sorry, Dr. Anosike.
Can you not see it? Okay, I'll just share it again.
Yeah, please.
Just let me know when you can see the screen. Can you see it now?
Yes.
Yes, sir.
Okay, great. So we don't have the pre-treatment MRI for this patient, as she couldn't make it available for this meeting, but we have the post-treatment scans. So patient had some cycles of chemotherapy, as was described by the medical officer, and we've got a skin marker, it's the marker in the breast at the site of the lesion. So you can see that dark structure causing some signal void in that MRI scan in the left breast. So that's the site of the tumor, or where this tumor was before. And if you look closely, you can see there isn't anything enhancing. That is, there's nothing that is bright around it. All of these things you can see that are bright on the scan are just normal fibroglandular tissue in this patient. So there's no residual tumor to be seen on this scan. Looking at both the post-contrast and the subtraction sequences, we can't actually see any residual tumor, so showing that the disease seems to have responded to the treatment the patient had. At the same time, the patient also had a CT of their chest, abdomen, and pelvis, and there was no metastatic disease.
Okay, thank you very much, Dr. Anosike. All right. So Dr. Zelu, from what you presented, this patient is now coming for consideration of further therapy. So having gotten the neoadjuvant therapy, chemotherapy plus anti-HER2 therapy, we now have a very good radiologic response. So I saw Dr. Lumati on the list of participants. So I think the patient is coming back now to have a discussion about surgical therapy. So, Dr. Lumati, I don't know whether you could unmute yourself and give some thoughts about how you would approach this patient.
Yeah, good morning, everyone. Thank you so much for the opportunity to participate today. It sounds like this patient has had a pretty excellent response to neoadjuvant treatment. I think she would certainly be a candidate for breast conservation therapy. The one part that I wanted to make sure I clarified was that her axilla clinically and radiographically negative for lymphadenopathy?
Yes, ma'am. Clinical examinations, the MRI, and the CT of the chest, abdomen, and pelvis revealed no axillary lymphadenopathy bilateral.
Okay, fantastic. I think she would be a candidate for breast conservation, which would be, a lumpectomy plus post-lumpectomy radiation. I think the only challenge in this situation is that since she's had pretty good radiographic response, it would be very challenging to localize this lesion, without sort of the lesion being kind of marked on the pre-treatment, before treatment. And so does she have any sort of residual scar there, or was this lesion palpable, or was there any sense on clinical exam where this was?
I think there was a marker placed. From what
Okay.
Dr. Anosike showed us. There's a marker.
Okay.
I'm not sure the
Okay.
exact nature of the marker, whether it's something, well, probably something that can be picked up with ultrasound, intra-op imaging. Dr. Anosike, would you agree?
Yes.
Okay.
Yes, it should be. You should be able to pick it. It's quite close to the skin. So I don't know if you can see my screen, Dr. Lumati. That's the marker there.
Okay,
Okay.
we're not seeing the screen
We don't
right
see
now.
the screen,
Not
but
seeing it?
okay. I'll
Yeah.
believe you if you say it. So I think I would ultrasound this patient,
Sorry.
examine and ultrasound this patient in my clinic, and then kind of recommend that she undergoes a lumpectomy with sentinel lymph node biopsy, as well as post-lumpectomy radiation. Given her age being a cancer less than the age of 50, she would also probably, I would recommend genetic testing, because she may have, not just the BRCA1 or BRCA2, but there are certainly a panel of genes, ATM, CHEK, PALP, other genes that are associated with a hereditary risk for breast, ovarian, prostate, and pancreatic cancer. So I would recommend genetic testing. And also, given that she is hormone receptor positive, she would also benefit adjuvantly with continuing anti-HER2 treatment, as well as probably tamoxifen, given that she's premenopausal.
Yes,
Okay.
ma'am. She's
A couple of questions, please, for you, Dr. Lumati. One would be if you can just briefly enlighten the audience about the role of sentinel lymph node mapping, why we do it, what the benefits are, and then also maybe you can highlight how that information about genetic testing will be used not only for the patient, but for her family members also, please.
Yeah, that's a great question. So I think, the sentinel lymph node biopsy for patients that are presenting with an invasive cancer has sort of evolved and become a standard of care in terms of how we manage patients with breast cancer. We know that a certain number of patients, even with, clinically and radiographically negative axilla, do also develop lymph node metastases and in the distribution of the axilla first before they become systemic. And so this gives us a way of sort of maybe trying to predict what patients are going to be at highest risk for lymph node metastases, and also trying to tailor our treatment in terms of how we manage the patients, adjuvantly. Historically, all patients with breast cancer basically got the Halsted Halsted Hopkins mastectomy, which was a modified radical mastectomy with an axillary dissection. But we recognize, with multiple studies, and I'm not going to go into the details of that was pretty morbid, that we can actually avoid an axillary dissection in many patients, and the literature around this is sort of evolving. But we use this to sort of stage the axilla, and the information that we get from this helps us determine how to plan our treatments in the operative and at the post-operative state. In terms of the information on genetic testing, there are guidelines regarding who should be recommended for genetic testing. So we typically think of patients that develop cancer below the age of 50, patients with triple negative cancers, patients with a strong family history, patients that are Ashkenazi Jews, patients with recurrent cancers, bilateral cancer, or anyone that's concerned about their increased risk for breast cancer as patients that we recommend genetic testing, or patients that present with ovarian or prostate cancer. And this information is helpful, one, because if we know that you have a BRCA mutation, for example, that has been associated, for example, for patients that present with a unilateral cancer, it's associated with a 40% to 50% increased risk of a contralateral cancer. And so a lot of these patients sometimes will elect to go ahead and get a bilateral mastectomy at the time that they have an invasive cancer, which again helps them to prevent getting a subsequent cancer, but also helps with the cosmesis of having a unilateral mastectomy. Not only for the particular patients, when I'm talking about the BRCA mutation, for example, they're also at risk for ovarian cancer, but also for their families, because the guidelines for screening for other cancers, if you have a family history of BRCA, or if you have a child and they tested BRCA positive, those patients' kids need to start screening for cancers at a much earlier age, as early as 25, with MRIs, and then 30, and when they get to the age of 30 at mammogram. So all of this is sort of used to try to prevent cancers in patients that have a strong family history in their descendants.
Thank you very much. Appreciate that. Now, I think we have Dr. Tumour and Dr. Agbakuru on the call in terms of adjuvant radiotherapy after resection. Dr. Tumour, I don't know whether you want to make any comments on that.
Yeah, good evening, sir.
Good evening. Good afternoon.
Yeah, thank you very much. Yeah, we usually do that, especially after conservative surgery, within the 8 to 12 weeks post-surgery. We usually recommend to do external beam radiotherapy, where some school of thought believe that you can do the whole breast first and cone down to the tumor bed, and some just do straight away to the tumor bed. It depends on the protocol in an institution, right? But it's expected to be done within 8 to 12 weeks post-surgery.
Okay, and what lymph node basin would you cover? In terms of axillary, supraclavicular, internal mammary, lymph nodes. How do you go about those decisions?
Well, during the surgery, there's axillary lymph node sampling, and we see any lymph node positive. Some surgeons, they prefer to do axillary dissection if they are all negative. They won't bother to radiate the axilla. But if there's any positive lymph node at any level, they will also radiate the axilla as they are radiating the breast.
Okay. So I believe, depending on the size of the lesion, the number of lymph nodes involved, you might want to extend to the supraclavicular space, to the internal mammary chain, if you have higher kind of disease burden in those situations.
Yes, I agree.
Dr. Agbakuru, I don't know whether you're there, whether you want to make any comments about this. If not, Dr. Ayodele, I don't know whether you're there. there was a question about the choice of neoadjuvant chemotherapy. I don't know whether you can address that and then talk about the post-op anti-HER2 and hormonal therapy also.
Thank you, Prof. My name is Dr. Ayodele. I'm a consultant medical oncologist, and I'm really grateful for this opportunity to be here. So I think the first thing is for a teaching point is, why did we get this patient to have neoadjuvant treatment in the first place? Because we know that surgery is the, how should I say, ideal treatment in quote, in order to cure a patient. However, we have different types of breast cancer based on receptors. Can you hear me?
Yes, we can hear you. Thank you.
All right. Yeah. Okay. So based on receptor status, so there are certain breast cancers that we would recommend neoadjuvant systemic therapy for. And those would be patients who have HER2 positive disease and patients who have triple negative breast cancer. The recommendation is usually what we call T2 disease. So T2 disease would be any disease above 2 centimeters. It can be a T1 disease if it has nodes involved. So for this lady, I think the MRI showed multifocal disease measuring about over 4 centimeters in size when you look at the whole tumor size. So this was the reason for recommending neoadjuvant systemic therapy for the patient. To go back to the question, why paclitaxel? So we know that based on several trials, which I would mention in a bit, we know that combining dual HER2 blockade with taxane, so either paclitaxel, nab-paclitaxel, or docetaxel, induces what we call complete response and increases the rate of complete response in patient. And pathological complete response is a surrogate or a good marker to determine how patients would do in the future. So when we talk about the cancer coming back, these are the things that we look at. So we used to use only trastuzumab ages ago. However, since 2011, we had trials like Trifina and Neosphere that showed that adding pertuzumab with trastuzumab made the rate of PCR higher. So therefore, that became the standard of care. So the standard of care would be to combine this dual HER2 blockade with a taxane. And usually, sometimes this is given with anthracyclines afterwards. However, these trials are showing that using upfront taxanes and dual HER2 blockade is the best way to go. So if we look at Trifina and Neosphere, the PCR rate was before the addition of anthracyclines. We've also had newer trials now like Adapt HER2 Plus, which has shown that just giving even just 3 months of HER2 blockade plus taxanes is enough to induce PCR, and then patients go on to have surgery. And then if they have residual disease afterwards, they can then get what we call TDM1 or trastuzumab emtansine, which is another drug, for about a year. So for this lady, she looks like she's had good response radiologically. So we really want to get her to surgery to see what will happen. If she has complete pathological response on scan, on the biopsy that comes back, or from the resected specimen that comes back, then because she's node negative, you can downstage her to receive only trastuzumab. If she was node positive, then you will keep going with the dual HER2 blockade for a year. If she has residual disease, then you would escalate to trastuzumab emtansine for a year, which is about 14 cycles. Because she's ER positive, I think Dr. Lumati also mentioned that, she will get hormonal blockade as well, so for at least 5 years. She is 47, so she is still premenopausal. So ideally, she should get tamoxifen. If she was node positive, then like I mentioned, that you can then switch her to TDM1. After she's had the TDM1 for a year, then you continue with the hormonal blockade. If she was node positive and residual disease, you would try to give her up to 10 years. That's the new guidelines rather than 5 years, but we'll wait and see what she has.
Thank you very much. That was excellent. Dr. Olawaye, with these patients, when they do have BRCA mutations or other mutations on genetic testing, how does that impact the management of their ovaries? I don't know whether you want to make any comment on that.
Absolutely. Thank you. So first of all, going back to the previous comments, I completely agree with what the commentator mentioned about the need for neoadjuvant therapy. But there are two other conditions where you give neoadjuvant therapy, and paclitaxel or taxanes are very active for breast cancer, some of the most active agents, but we have others, including anthracyclines and all that, with all the newer agents that block HER2 for the HER2 positive cohort. But the two conditions that make us give neoadjuvant systemic therapy, like in this case, one is, in both of the conditions, a conservative surgery on the breast is planned. The patient is not planning to have the whole breast removed, but there is what we call high tumor to breast ratio. So you are going to be taking too much of that breast tissue. So in that situation, you can give neoadjuvant systemic therapy in order to reduce the tumor to a size that will make the conservative surgery cosmetically good at the end of the surgery. That's one condition, of course, with all the other additions based on what the tumor resection shows. Then the second condition is actually based on not the size of the tumor, but the location of the tumor in the breast. If the location is such that you think going after it is going to result in a cosmetically suboptimal cosmetic outcome, you might elect to use systemic therapy to make that not the case. So you're using it to reduce tumor size so that you can do a much better cosmetic job when you do the conservative breast surgery. Now, with BRCA, going back to you, Dr. Wogo, the BRCA1 and or2 carrier, I actually just took care of somebody who has both, which is most unfortunate. The risk of breast cancer, for ovarian cancer, is very high. With BRCA1, roughly about 50% lifetime risk. Some would say 45%, and with BRCA2, about 15%. These patients, we consider their risk of ovarian cancer let me use the appropriate word, unacceptably high. And remember, unlike breast cancer, there is actually no established screening for ovary cancer, none. There are things that people talk about, but they're not by any international standard accepted as valid screening for ovarian cancer. So there's no screening, which is why most of them are still diagnosed in advanced stages. So when people have BRCA1 and 2 being the major ones in the HR space, there are many others, but those are the big ones, and they account for about 70% of all genetic mutation-related ovarian cancer. We advise the patient, once they complete childbearing, to consider prophylactic surgery, which is removing both ovaries and tubes. And two things I'm going to say about those. One is, most ovary cancers, the so-called ovary cancers in BRCA1 and or2 carriers, actually originate from the fallopian tube, or from the fallopian tubes, not from the ovary. And that is another discussion entirely. So we have a study going on right now in the United States where we are comparing removing just the tubes and conserving the woman's hormones, especially the fact that many of them are premenopausal when they are going through the surgery, and seeing whether that is as safe as removing the ovaries along with the tubes, which if we can get away with just removing the tubes, it would conserve the hormones of the woman and make her not go into premature menopause. The uterus being removed, we think that is more important in BRCA1 carrier or carriers, because there is the risk of serous endometrial cancer is about 2% in people that lifetime risk in people that carry BRCA1 mutation, compared to the general population where the risk of that particular very dangerous cancer is 0.2%. So it's 10 times higher. And therefore, if you have a BRCA1 mutation and you're considering prophylactic surgery, we think it's wise to consider having a hysterectomy. Thank you.
Thank you very much. Thank you. Appreciate that robust information. For Dr. Fred Obiajulu, maybe you can enlighten us a little bit. One of the challenges we're having with management of breast cancer is the availability of immunohistochemistry in a timely manner. I don't know whether you could give us any thoughts on that, and general advice in terms of the rapidity of diagnoses. We've also been pushing to have people do just core needle biopsies rather than doing these almost like diagnostic excisions that are not cancer operations. So I don't know whether you can talk a little bit about immunohistochemistry and talk about the robustness of making diagnosis with a core needle biopsy. Dr. Obiajulu, thank you.
Okay, thank you, everyone. I think immunohistochemistry has become standard test for breast cancer, and nobody, I think for now, manages breast cancer without immunohistochemistry. So it's very important that this is requested together. At times, delays come when we'll type of how the patient pay. So if you make requests together and this is carried along or with the request, initial request, it makes it faster. That's one thing. The next thing is about the core biopsy or excision biopsies. The core biopsies actually say they're faster. It takes shorter time for you to report and then do immunohistochemistry. In-country immunohistochemistry is available, and many centers as well as ours are optimizing and even advancing to set up automated ones that will even be more efficient and effective in terms of not going manual because of a little bit of challenges you have in going manual. And these core needle biopsies, if well taken and the cores are neat and neat in terms of the number of cores and well taken is good. I can also extend it to say that good cell blocks, FNAC with good cell blocks, can also serve for immunohistochemistry because that can be transferred to cell block and then you can do immunohistochemistry with that. Though fine needle aspiration cytology is not a standard practice now in most advanced countries, but I will say that sometimes in our environment get adequate cell blocks and have been used to do immunohistochemistry. So patient can quickly get fast treatment, not even waiting on core needle biopsies. What delays immunohistochemistry in our environment, I can say one is time you make the request, ability of patient to pay at times. You need to inform them that, okay, this diagnosis has been made. Can you pay ahead? Then funding will be there. At times, some patients have HMOs. You need to get approval for them to approve for their immunohistochemistry to be done. And this takes time. I think it's important as a team, we have to let these HMOs know that for proper management of this patient that have for breast cancer, these three important tests should be accounted for immediately, not waiting for your approvals to come for us to do this test. At times it takes them, I'm telling you, 2 weeks for them to approve for these things to be done and calls to be made. Another thing that delays immunohistochemistry is preservative. Some people preserve in not 10% buffered formalin. And if that is not done in this right fixative, at times the immunohistochemistry is affected, especially HER2. So it's important that you preserve well in 10% buffer, neutral buffer formalin, so that subsequent tests, both your immunohistochemistry test will come out well, and even if you want to do genetic testing, that will also be nice.
Thank you.
I think that is all I can say on that.
Thank you very much. Appreciate that. So we've had a very good, robust discussion about this first case. I don't know whether there might be one or two questions for the audience before we go to the next case. There'll be time also at the end of that case for general questions. So maybe one question before we go to the next case, if there's any. I'm scrolling through a little bit to see whether any hands are raised. You can put it in the chat also, as Dr. Oge Ilebune had mentioned.
There is a comment in the chat from Jalilat Momodu, who would like to add a comment about sentinel lymph node biopsy.
Okay, some comment that was not covered by what Dr. Lumati had said earlier. He said he wants to make, if he wants to make a comment, he can unmute and make a comment about that. Sure.
Good evening. Thank you for the opportunity. I'm Dr. Jalilat Momodu, nuclear medicine physician.
Okay, well, you're welcome.
Thank you. So with regards to sentinel lymph node biopsy, I just wanted to add that although it's standard of care now, not every patient, it's not indicated in every patient with breast cancer. So the concept behind that is we're looking for micrometastasis. So even though on morphological imaging, there's no evidence of axillary lymph node involvement, there might be micrometastasis which would not be visualized on morphological imaging, which is why we would then consider the sentinel lymph node biopsy. If you have patients where lymph nodes are already apparent on anatomical imaging, then you will also consider other types of functional imaging, such as FDG PET or FES. So I just wanted to add that.
Yeah, thank you very much. Thank you. In this era of neoadjuvant therapy, some people who have clinical lymph node disease after that treatment might have, kind of a great response. So we've actually been talking a lot about being able to put a marker in some of the lymph nodes that are involved before we give neoadjuvant therapy, so that we can identify those lymph nodes. And then as our breast surgeons and surgical oncologists would always point out, in addition to that particular lymph node, we want to see which other lymph nodes might potentially be involved. One of the things I might ask you is we have a challenge with availability of technetium. So most, Western countries do a double dye technique. So there's the blue dye, and then there's a radioisotope, which is usually technetium-99M. Now, we have one cyclotron in Nigeria, I think Mikure. I've had conversations with them about production of technetium, but right now they're focused on just FDG. Do you have any comments about when that will be available in our community? Technetium for sentinel lymph node biopsy?
Yeah, thank you for the question. So technetium is actually not dependent on the cyclotron. So we have what we call the molybdenum technetium generators, which will produce your technetium radio tracer. And I know that currently in Nigeria, there are some centers where this is available.
Okay.
So yeah,
that's very interesting.
Yeah, so Mikure would only be able to produce cyclotron-based tracers like FDG or PSMA for prostate cancer. But if you need technetium-based tracers, there's some private hospitals and government hospitals where this is available in Nigeria.
Okay, thank you. We'll make a note, please. Our business development team, make a note of Dr. Jalilat Momodu, and we'll follow up with you to try and get that available for our patients. Thank you.
I have Dr. Momodu's details. Hello, Dr. Momodu.
Hi, Dr. Hi. Thank you for the invite. Yeah.
How are
You're
you?
welcome.
You're welcome.
whilst we're on that subject, if I may just say, you know, in the evolution of sentinel lymph node dissection, whichever organ site you're talking about, the dye, which is isosulfan blue in most cases, and the technetium-99 iso molecule are the two most popularly used, and they've been compared with blue dye alone and so on and so forth. There's no question that technetium-99 is the superior, you know, tracer of the two. If you must have one and not have the other, you probably will do technetium-99. So it's so critical that we have it, because the blue dye sometimes is readily obvious, but often you are already in the vicinity of that lymph node before you actually see the color change. Whereas with technetium, it's so much easier. You just trace yourself there. It saves time. You cause less bleeding, and it's more precise when you combine both of them.
Thank you.
Yes, absolutely.
That's why we have these webinars, right? We educate ourselves and find out things that we didn't even know existed around. I mean, this is the first time I'm hearing that technetium-99 is available for sentinel lymph node mapping in Nigeria. That's great. Okay. All right. In the interest of time, Dr. Iwuji, do you think we should go ahead with the next case?
Yes, please. I think we should go ahead with the next case. So, Dr. Ebuka, are you ready to present the prostate case now, please?
Hello, good evening, everyone. So I'll be presenting this gentleman. This is initials with NG. He's an 81-year-old male with a recent histological diagnosis of adenocarcinoma of the prostate with Gleason score 5+9. He's actually a non-hypertensive and diabetic patient. I just want to give a bit of a history before we proceed with the other slides. He's been having a lower urinary tract symptoms, which has been going on for a while, since early this year. You know, I think he went to the clinic and I think they started him on tamsulosin. I think they were guessing he had BPH, so they started him on tamsulosin around February of this year, which didn't stop the symptoms. They went ahead to give him Casodex. That was by April. You know, so while doing that, he didn't see any reasonable improvement. However, he did a PSA test done. The PSA came back and showed that he had 30 nanograms per ml, which considered very high. And they went ahead to do a biopsy. So the prostate biopsy was done. The number of calls were not determined, but it was found out that all but one of the calls had cancers. So mostly all the calls, except for one of the calls, was free of cancer. And in each of the calls had over 30 to 70% of the tumor cells. So, and which came back with that diagnosis. And he went ahead to have an abnopelvic MRI, which essentially showed he had no extra prostatic disease, as well as no lymphadenopathy. And also, we also requested for a CT test for this man, which came back and showed no distant metastasis, and the chests were essentially clear of disease. So we are presenting this man today to look at his pathology, as well as determine what is the best way to follow this treatment, in terms of the fact that he started some form of ADTs already. Thank you.
Prof. Ogo, I think you're muted.
Sorry about that. Sorry. I think we'll do, thank you. We'll do the imaging first and then go with the pathology, please. Dr. Nasike, do you have...
Yes, I'm just going to share the slides. I think there's a bit of a lag with the system. So if you just, can you see the screen now?
Yes, please. Yes, please.
Yeah, okay. So this is an axial T2 sequence showing this patient's prostate. There's some measurements on there. So the first thing we normally do is sort of get a volume of the prostate. And in this case, the patient's prostate gland was about 30 cubic centimeters. And he has a PSA of 30. So the PSA density of the patient is pretty much like 1. So PSA density above 0.1 normally confers an increased likelihood that you've got clinically significant tumor within the gland. So if you look at this prostate, you can see there's abnormal tissue in the peripheral zone of the prostate from 4 o'clock. So we sort of use the clock face on this axial sequence to read it. So that's 12 o'clock, 6 o'clock, 9 o'clock, 3 o'clock. So if you start from 3 o'clock to about 7 o'clock, you can see abnormal tissue in the prostate. This is the T2 sequence. So it's, what I call the evil gray. So there's gray tissue in the peripheral zone of the prostate. So quite an extensive tumor. And it's breaching the prostate capsule. So you can see all these strands of tissue extending beyond the capsule. Now, the things that control your erection as a man tend to run in this region. So in this triangle, I don't know whether my pointer is showing or not. The tumor is extending beyond the gland and it's involving the nerves there's the neurovascular bundles that control the patient's erection. So it's extended beyond the capsule, involves the neurovascular bundles, but it doesn't involve the seminal vesicles, which are sat here. So the seminal vesicles are fine. And again, the other structures that prostate cancer can affect would include the bladder neck. So this is the bladder. The bladder is free of tumor. Again, you can get extensive tumor in some cases involving the rectum, but that's not the case here. So bladder is free, rectum is free, and seminal vesicles are free. So that makes it a T3A bladder tumor. There's no nodes in the pelvis, and also superior chain nodes. We haven't got the pictures of the abdomen, so I can't really comment very much on that. So essentially, this patient's got a prostatic tumor with extracapsular extension, making it a T3A tumor, and there are no nodes. So the MRI staging is T3A and 0.
Thank you very much. Appreciate the detailed imaging. You can see how this helps us in determining therapy when we have such a detailed imaging. So, Dr. Obiajulu, I don't know whether you have any slides to share on this patient.
No, I don't have slide on this.
Okay.
I wish I, yes. Yeah.
Okay. So sometimes if we have slides, that's helpful. But this patient, I think, has been confirmed to have prostate cancer. I don't know whether you have any comments on, the number of core biopsies that are done as you do this interpretation. Do you have any guidelines? I don't know whether you can comment on that. Dr. Chinegwundo was going to be here. I don't know whether he's joined us or not. But Dr.
Okay.
Yeah.
I'll just comment. Yes, I can say I will say I use a just ritual one, like the more the merrier. So the more I have the tissue, the higher chances of getting the diagnosis. So in just to bring it down to the is to say that, so they use I think they do sextant biopsies. Unfortunately, some people will just give you 2 cores, 3 cores. There's no, but I think the standard I would say minimum I can say is 24 cores. At least the sextant biopsies minimum, and then two cores each from there. Minimum of 2 cores from all the biopsies, sextant biopsies. Some go extend to divide it into 9 and obviously give you more cores. So the more you are able to, the more cores you give, the better. But I would say minimum of, I would say standard would say 24 cores. Take 2 each from each of the sextant, and some actually give you 4. So that would be a better, especially when you suspect malignancy, because we know how big this process can be, and if you don't sample enough, you may actually miss okay, 12 cores. All right, some people say 12 cores, but yes, 6, 12. Sorry, yeah, 2 times 6, 12. Yes, 12 cores. Yes.
Okay. Thank you. I think Dr. Ayodele, maybe you can enlighten us on 2 things. One is, yes, maybe if you have a few comments to make about the sextant biopsies. But one thing we see very commonly in our kind of practice is the rush to start androgen deprivation therapy, even before
proper staging and determination of the ideal therapeutic approach. So I don't know whether you can make any comments on that.
Thank you, Prof. Yeah, so this has been a big problem that we've seen many times. So just as a broad way to look at prostate cancer, so it's not every prostate cancer that should be treated. There are things that we look out for in order to what we call risk stratify these patients. So basically, we want to look at people's PSA levels. We want to look at what is the age of the patient. We want to look at what we call the staging on MRI, which is why MRI staging is needed. And those things would put the patient into what we call risk stratification. So based on risk stratification, only intermediate and high risk or very high risk really should be given androgen deprivation therapy. A lot of times this patient can be managed by what we call watchful waiting or active surveillance, because like we said, it all depends on the course that has been checked. So if someone has, like we say, adequate course should be 12. So if you have less than 25% of those cores positive, patients can still go under active surveillance. The only problem with the active surveillance is that it's quite intrusive. So it means that they would have these biopsies every year or thereabout based on the PSA levels. But going to the management of this patient. So going back to this patient, we've seen that he has a few high-risk factors. He has a Gleason score of 4 + 5, which is 9. So anyone who has a Gleason score of 8 and above, and for people, the highest is 10. So 8 and above would be considered as high risk. He has a T3 disease, which also supports high risk. His PSA is greater than 20. So definitely with all of those, he has what we call high risk features. So definitely that moves into staging the patient for metastasis, because if they have high risk disease, then you worry that they might have metastasis. So the two ways that we check for metastatic disease, one is CT scan. The second one is a bone scan. So those are the two ways, because prostate cancer is known for going into the bones, which is why the bone scan is very important, because it can be missed on CT scan, but bone scans are better. These days we talk about PSMA PET scans. It's still not the standard of care. Some institution has started doing it, but it's not I just have to say, it's not the standard of care yet as a staging for these patients. So, but we would want to do a CT scan and a bone scan at least for this patient. And then based on that, we then decide what next to do for the patient.
Thank you very much. Appreciate that. We have Professor Chinewundo, who is a urologist in the UK, who can also make some comments. There was a question about sextant biopsies, how many cores should be done. I know you have also been teaching us about the pros and cons of transrectal versus transperineal biopsies. So maybe you can make some comments about those biopsies, if you could.
Yes, thank you for the invitation to make some comments. If we start off with the biopsy, in the UK, no one now does transrectal biopsies. All the biopsies now are done transperineally, mostly under local anesthesia, where you inject the local anesthetic into the perineum and you have your transrectal ultrasound probe in the rectum, which helps you direct where you take your samples from transperineally. And the reason we switched from transrectal biopsies was because of the risk of sepsis from transrectal, or some people would term it transfecal biopsy.
Yeah, thank you. How about number?
Yeah,
go ahead, sorry.
Yeah, and so we do transperineal biopsies, and we divide the prostate up into 6 areas, and take 3 to 4 samples per zone, which is somewhere like 18 to 24 biopsies. Now, if your MRI scan shows you a particular lesion, then you can target that lesion. Now, when it comes to the case under discussion, I would agree entirely with the previous speaker. This man has got at least locally advanced disease. He may have metastatic disease, which the bone scan and CT scan would tell you, but he's got aggressive, that's I think Gleason 8 or Gleason 9 disease, and it's T3, which means it's outside the prostate gland. Now, I would say that we would be looking at starting this man on hormonal therapy, plus or minus external beam radiation. And if he's got metastatic disease, then we know that we're in a situation of palliation. If the disease is just locally advanced and not into the bones or the lymph glands, then radiation, external beam radiation, 20 fractions will give him a reasonable chance of longevity.
Yes, thank you very much. I think Dr. Momodu wanted to make some comments, maybe about the role of nuclear medicine in staging. Did you want to say something?
Yes, thank you again. So for this patient, based on the PSA and the Gleason high-risk patient, as part of the staging, I think both the European and American guidelines actually state that PSMA-based imaging is an indication for, it's indicated in staging these high-risk patients. And the reason why is with bone scans, there is because of the lower resolution of the camera, you can miss lesions, and the bone scan will only tell you if there's metastatic disease in bone. And then another challenge with bone scans is the chance of having false positives, because prostate cancer is not the only cause or reason for uptake on a bone scan. So right now, standard of care actually advocates for PSMA-based imaging, which is more focused on the prostate cells, so prostate cancer cells, regardless of where they are. The other advantage of PSMA-based imaging would be you can also get information on visceral metastasis. So in addition to bone, you get information on visceral metastasis. And because the PET camera has a higher resolution, lesions that were not seen on anatomic or morphological imaging or on bone scan, you would appreciate on a PET scan. But I also want to highlight that PSMA-based imaging is not only PET. So you actually have technetium-based PSMA tracers as well. So I just wanted to highlight that because studies have shown that in up to 30% of cases, a PSMA-based scan would upstage the patient. The other thing I wanted to highlight in terms of the cause, this is purely anecdotal. One of the previous speakers said, the more the merrier. We actually had a patient who had a total of 13 biopsies over a number of years, and they all came back negative. But his PSA was rising continuously. So he was referred for a PSMA PET scan. Luckily, this was in a center where this was readily available. And from the PSMA scan, we're able to actually direct the pathologist in terms of where to take the biopsy from to get a positive histological diagnosis. So those are the things I wanted to highlight, that in this patient with high risk, definitely consider PSMA-based imaging in staging this patient, because there's a chance of upstaging the patients, which would impact on the management. Thank you.
Is there any center doing PSMA staging? And
PSMA,
right?
yes. Lakeshore has PSMA because they have a PET scanner.
I know. Initially, they told me they were just doing only FDG PET. So
they've resumed. Yeah,
okay.
They've resumed PSMA. Yes.
Okay. Great. We have
Thank you.
Dr. Ibrahim Yusuf. Thank you so much. Has his hand raised. You have a comment, Dr. Yusuf?
Yeah, thank you. Please confirm you can hear me.
Yes.
Thank you. Yeah, first I must say I've enjoyed myself in this session. But one big issue for me, and especially in our system, we focused, which is quite excellent, more or less like updates for specialists, on this call. But even the basics in terms of, I mean, you only need to see one or two of these cases to see how badly, our colleagues would now knows, or think, look, PSA is a thing. Once it is high, then you must have these, and, and that for me, gives headache to the Lakeshores of this world, the Marcel Ruth of this world. Even if we have to mean, and this is a plea now, it will have to mean, having these sessions, that speaks to a bit more basics, maybe that would have some impact such that people are not badly, managed, either from breast cancer or prostate cancer that we've talked about here this evening. Thank you.
Yeah, thank you very much. We're definitely doing our best to try and pass best practices to our primary care physicians. There's so many instances where this is a challenge. One of the biggest things we see all the time is these excisional biopsies for breast cancer. Huge problem. I think Dr. Anasike and then Professor Chinegwundo, you wanted to make some comments. We still have to touch a little bit about the recommended therapy for this particular patient.
Yeah, just a quick comment on Dr. Momodu's mention of PET. While it's valid that it's recommended due to the high sensitivity, it's not been my experience in the UK that because of accessibility to PET and resource constraints, we found that a very pragmatic approach, which is what we need in Nigeria based on the cost of some of these things. I mean, a PET scan costs nearly 600,000 in the previous exchange rate, probably closer to $1 million now. You have to kind of be pragmatic in the staging, which is pretty much how we practice in the NHS as well, because you don't have PET scanners. Access to PET scanners currently in the NHS is about 6 to 8 week wait. So patients with locally advanced prostate cancer currently are not having PSMA PET. They are being staged with bone scans and CT scans. And the combination of those two, you're getting sensitivities that are closer to about 80%. I know with PSMA PET, you're getting 92, 93. But I think what we've done is to have a pragmatic approach of using two tests that could potentially push the sensitivity. Bone scan alone, you're at 60%. If you add a CT to it, you're getting closer to, late 80%. And that's pretty much how things work currently in the NHS. So not disputing the guideline, but I'm saying that especially in our environment where we've got challenges with resources, a bone scan and a CT would be the more pragmatic approach.
Thank you very much. Appreciate that. Professor Chinegwundo, you wanted to say something also?
Yes, it was, in fact, Dr. Anasike has said exactly what I was going to say. We have a pragmatic approach, even in a center of excellence, to PSMA PETs. It's not easy to get. There's a shortage of the tracer, so we're very selective about who gets the PSMA PET. So it is still CT and bone scan for the majority.
Thank you. We definitely are very, very cost conscious in Nigeria, given the fact that most people pay out of pocket. It's a very important question.
Yes, sorry. This is Dr. Mamodu. So I just wanted to add, I probably wasn't very clear. So there is SPECT-based PSMA imaging, not a PET. And this would be available in centers where they do a bone scan. So I'm suggesting if you approach a nuclear medicine department for a bone scan, you can ask them for PSMA-based technetium imaging. And most centers that do bone scan will most likely have it available. And I know that there's a center in Nigeria that has that available as well. So it's not a PET, it doesn't necessarily have to be PET, but there's technetium PSMA as well. And this will be available in centers that do bone scans. Thank you.
Thank you very much. Any comments? I don't know whether Dr. Ayodele, you want to talk about treatment, for this particular patient. Is it just ADT? What's the role for chemotherapy? I think somebody has asked a question about the use of docetaxel for locally advanced prostate cancer. Would you like to address that, please?
Yeah, thanks. So at the moment, for these very high-risk patients, based on the STAMPEDE trial, the NCCN guidelines will recommend that you can try 2 years of abiraterone in these patients. For node-positive patients, the ESMO guidelines still recommends probably discussing docetaxel. But from the STAMPEDE trial, we have seen that docetaxel doesn't give overall survival, and it doesn't give metastatic-free survival. So we're starting to kind of change our practice towards giving upfront docetaxel, because what happens is that the probability that this patient would relapse is high. And if they do, then you have used one potential good line of treatment for these patients. So if possible, so in my institution, we kind of come up with a guideline. So the people that we would discuss chemotherapy with currently would be patients who are less than 65, who are very fit, who are node positive, with a Gleason score of more than 8. So we would discuss docetaxel with those patients, but we try to discourage it because currently we don't have abiraterone. I think in the US you can get that. So they would use that in the US.
Thank you very much. The age, when you mentioned 65, I will tell you that in the US, I think Dr. Lawrence will agree. I mean, in the US, 85 is the new 65, you know what I mean? So you cannot eliminate people who are, in their late 60s, 70s from, aggressive therapy. You would get a riot. Professor Dr. Lawrence, I see your hand raised. You wanted to say something else?
Yes, thank you. Actually, just to home in on the point you just made, before I went on vacation, the last patient I operated on for ovary cancer is 87.
Yeah.
And she went home 3 days after. And but it's interesting when we talk about pragmatic approach. I just wanted to chime in on the PSMA based scanning, and that I'm heavily involved in standard setting over here, and that really is the standard. Remember, and those who are regularly at our tumor board, that when I give any advice, I most of the time anyway, take account of the resources limitation that we deal with in Nigeria and other sub-Saharan African countries. But what we should aspire to, which is one of the important things about this webinar, is really talk about what is best, and then talk about what else we can use in the absence of what the best option is. So I just wanted to focus people's attention on that. But if PSMA-based scanning is available in a patient suspected of having metastatic prostate cancer, it definitely is the current standard in the United States.
Thank you. Dr. Iwuji, go ahead, please.
Thank you. I just wanted to ask the question to Dr. Momodo again regarding the difference in cost between this technetium PSMA versus the PSMA PET that we've been discussing, and in comparison to this alternative of bone scan and CT scan, in terms of costing, how does that fit in, please?
Okay, thank you for the question. In terms of costing, technician-based PSMA is definitely cheaper than PET PSMA in terms of production, the availability of the vials to prepare, and also the logistics involved. So definitely cheaper. I am not sure of how it compares to a combination of CT and bone scan. But I know that in centers where technician-based PSMA is available, I would rather use it than do a bone scan, because a bone scan is also technician-based. So even if the PSMA scan is marginally more expensive than the bone scan, I'll rather do the technician PSMA because I will get more information from that scan.
Okay,
Thank you.
and you'll be able to skip the CT in that situation? Will you be able to avoid?
You can skip the CT in that situation because, like I said earlier, PSMA-based imaging is focused on micrometastasis. So metastatic lesions which would develop on those scans will most likely not light up on a CT scan. And I'll give an example. Even with the bone scan, lesions you find on a bone scan today will not come up on a CT scan until maybe 12 months later.
Okay,
yeah.
I appreciate that information. So this patient, Dr. Ayodele, so you were talking about ADT, androgen deprivation therapy, and anyway, from what you told us in your UK practice, you would not give him chemotherapy. You would just focus on ADT for now.
Yeah, we tend to move away. We're moving away from it right now. And like Dr. Momodu said, we've had a few patients who, if they're very high risk, that we're worried, we actually would do a PSMA PET, and we're finding out that they are upstaged, so they become metastatic, So I think that also changes the management of the patient. And just to say, so if we continue with this patient and we get a PSMA PET and it shows that they have metastatic disease, then they would be managed in a different way.
Yes. So Dr. Oge Ilebune, please let us, with Dr. Iwuji, maybe confer with Dr. Momodu to really understand how to go about this and figure it out. Before I forget, Dr. Tumour or any of our clinical and radiation oncologists, do you want to talk about radiotherapy in more detail, both for locally advanced disease and in some cases where you have symptomatic metastases? I don't know whether you have any comments to make, please. I don't know whether Dr. Tumour is still there. I didn't see Dr. Abakuru there. I don't know whether we have others who are clinical oncologists on this call that might want to speak to that. Dr. Tumour, I see you there. Okay.
Yeah, I didn't get the question, Prof.
No, I'm just saying,
I'm on the road.
Okay, sorry, yeah. Locally advanced disease, or in general, if you're treating non-metastatic disease, external beam radiation, we know we have brachytherapy available. And
Yes.
Chinebundu can also talk a little bit about brachytherapy. Yes. And then symptomatic metastases, just role of radiotherapy in this disease.
Well, yeah, thank you very much, Prof. For locally confined disease, that the PSA is less than maybe 10, and the Gleason score is around 6 or 7, and when the volume of maybe 50 MLS, so we usually offer them brachytherapy, and we do the curative dose for them, 13 gray in 2 fractions, day 1, day 2, or in some center, they can do 15 gray at a go and add external beam radiotherapy for that kind of patient. But in our setting, we just do curative, we do 13 gray in 2 fractions, day 1, day 2, and the patient will be on follow-up. But if there's involvement of seminal vesicles, we don't normally give them brachytherapy. We do external beam radiotherapy because brachytherapy cannot touch the seminal vesicles or even lymph node involvement. So we send that kind of patient for external beam radiotherapy. Yes, sir. That's what we do.
Okay. And then when you do have symptomatic metastases, you do palliative radiotherapy.
Yeah, palliative
areas.
to the metastatic sites, especially to the spinal mat.
Yes. And how many fractions do you typically give, over what period of time?
Where it depends on the centers, static grain and in 10 fractions, a time for palliative to spinal mat, or some center do 20 gray in 4 fractions. So it depends on the protocol and each center is using. It must not be more than 30 gray overall.
Okay.
Yes, sir. Yes, sir.
Thank you. Dr. Wuji, I don't know whether the other questions you see in the how available, Dr. Olawe is asking, how available and accessible is PSA screening in Nigeria? Okay, that's a great question. PSA is widely available in most labs. As we know, the question about standardization is an issue. Sometimes you have to, see the trends in particular labs, and Professor Chinegwundo can speak to this also. In Nigeria in general, we don't have, national population-based screening. So it's more of opportunistic screening. We do recommend it, if people can afford it, if those who can afford it, what to do. But Professor Chinegwundo, for those who can get screening right now, PSA, DRE, what would be a recommendation for every man in terms of screening in the Nigerian setting? Are you there, Professor Chinegwundo? You seem to be frozen, Frank.
I can hear you.
Okay, so screening recommendations. Yeah.
Yeah.
I think you might be in a poor signal area since you're driving. Yeah. So in general,
So Chumi, I mean, we can't hear the professor.
I know.
But that question is a targeted one. I mean, look at how much difficulty we have in, yes, Prof. I just wanted to add to maybe what you can contribute to, how much difficulty and the resources that are necessary to treat these patients. I can tell you from a personal experience, I know at least in the last 10 years, more than 12, 15 people whose dads, brothers, and very close relatives, including my father-in-law, were diagnosed with prostate cancer. Practically all of them, the cancer was advanced. So the screening doesn't prevent cancer, we know that, but it allows us to detect cancer many times in early stages when the options for treatment are many. And so I'm just sad and concerned that it doesn't appear that there is any health education directed at men, even though we all know that we Black men are at higher risk than other people. And yet, it tells that somebody can pay for. Nobody is even talking about it. I mean, in our country, in Nigeria.
Yeah, thank you. Dr. Ayodele, you wanted to say something, and then Dr.
Yeah. So it was just something that Dr. Olawe was mentioning. So 1 in 4 Black people would have prostate cancer, and I think it's something that hasn't been spoken enough. We kind of concentrate a lot on breast cancer, but prostate cancer is a big menace among Black people. And now the recommendation is anyone who is 45 and above who is Black should be getting PSA tested. So I think this is something we should start disseminating across and make people aware, because usually people think prostate cancer is a disease of old people. Not in Black people, unfortunately. The genetics is very different. It's more aggressive. It presents really, really bad, and patients are having really poor outcomes. So I think it's very important that we spread this to our loved ones and everybody around, that because you're a Black man, 45, once you hit the age of 45, if you don't have a family history, if you have a family history, actually even 40. But if you don't have a family history from 45 years, please start getting your PSA. And it's so simple. It's an easy test. It's just a blood test. Just get it done. Let it be part of your annual routine checkup.
Yeah, we've been pushing this, I must say. Dr. Ilewune has been leading the charge. We've been pushing this both from Lakeshore and the Foundation for Cancer Care. We've been pushing this for men. Generally, we just say 40. From 40 on, PSA, annual digital rectal exam, we've been pushing this message. Dr. Ilewune, any comments on that? Dr. Oge?
Yeah, thank you very much. I think Dr. Ayodele has said it all, really. We just need to continue with the education and awareness. And what we found is when you explain it to patients, they actually understand. So, the whole idea that sometimes it's ignorance. It's not ignorance because people really want to be ignorant, but we know in Nigeria, we don't really have a proper national screening program for all the 4 cancers that can be screened for. But once you start telling patients, they actually are keen to do it. And so, we'll continue doing what we do at Lakeshore. And there's, quite a few other facilities and diagnostic centers have picked up and are also doing the same. And we have the Nigerian Cancer Society led by Dr. Adamu, which has sort of brought all the different facilities and in the cancer space together so that everybody can have the same voice. And prostate cancer certainly is one that, everybody is beginning to talk about.
Okay, thank you. Dr. Yusuf and then Professor Chinegwundu, and then we'll have to wrap up. I think our director, Bindia Sadaragani, will round up for us. Okay, go ahead, Dr. Yusuf, please.
Yeah, so thank you once again. I'm not a resource person, but I just feel quite, sad and passionate, at the same time around what the last 2 or 3 speakers have talked about in terms of awareness amongst, families and friends. But that said, there is even a lot more that needs to be done, especially, and I'm sorry if I'm sounding like a broken record here, what people need to make of when people have gone to do their PSA, what to make of it, the digital rectal examination that you talked about. I mean, it's unbelievable, I don't know want to call it with a lack of knowledge or lack of, whatever it is, appreciation of what this means if, this is missed. And again, I'm looking to Lakeshore. I mean, I know that Professor Wogu will probably say, hey, look, okay, if you're asking Lakeshore to do this or as common sponsor, but hey, if that's what would have to be in a way that it would have the necessary impact among our colleagues who, who are the front line here. Thanks.
Yeah, thank you very much. Professor Chinegwundu, you had your hand raised previously. Do you want to say anything more about this?
Yes, I was just going to say that we're now saying that if you're Black, you should start your PSA screening at 40. We used to say 45 years, and then we used to say 40 if you have a family history. We're now seeing prostate cancer in younger and younger Black men. So we're now advocating age of 40. Of course, there's quite a lag time between observed experiences and guidelines reflecting that. But we're certainly putting it out in the community that you should start from the age of 40. And certainly, yes. I mean, there is some evidence from the continent that, particularly from Germany, that you get a baseline at 40. Depending what your PSA is, 40 determines the interval testing regime. Yeah, so age 40.
Yes. Absolutely. Lots of questions in the chat about this. PSA is not a perfect test. You can have elevated PSA from things like prostatitis, but that's the best that we have at this point. That information needs to be discussed with somebody who is experienced in managing these types of diseases. So to Dr. Yusuf's point, how you use that information is very important. People like Professor Chinegwundu would follow it and see what the trend is. Is it rising? Is it stable? Is it dropping? Sometimes we'll get antibiotics to potentially treat prostatitis, repeat the test, see what's going on. So there are lots of things that need to be done. Dr. Ayodele, go ahead. You have some comments?
Yeah, it's just, that's the whole point of screening. So there are always going to be false positives in screening, but it's a screen, it gives you an awareness. So it's just like mammogram. So you would have times where you can see calcifications or something on mammogram. It doesn't necessarily mean that it is breast cancer, but then you will find that it's it would then be investigated more. So it's basically trying to investigate, because I think there is a question in the chat saying that, do we have the evidence to advise every 40-year-old Nigerian to have PSA tested, given that even most prostate cancer won't cause problems? The problem is that this type of cancers that we're seeing in Black people is quite aggressive, and even some of them don't have raised PSA. That's even the funny part of it. And even they tend to transform very quickly into other somatic types. So I think it's just the awareness. There'll always be false positive, but you cannot rule out that to say that you can use it as a good method of a screen currently. That's the best we have.
Absolutely. Thank you. Dr. Lawa,
Yes, I completely agree with Dr. Ayodele. And in answering the question that was posted in chat, I saw that question too. Please remember one thing, that the literature that is available and widely talked about are heavily skewed to the majority population in the West, who are Caucasian, mostly European origin people. That does not apply to you and me, my friend. When you begin to tease out even epidemiological studies, you will see that the trajectory of different races are very different, which is eloquently put by Dr. Ayodele. When you say PSA may not actually impact outcome, that is talking about white population. Unfortunately, when Blacks develop prostate cancer, they have the aggressive variants. And let me say something that is uniform to all cancers, solid tumors. Your best bet to push back on an aggressive cancer is to detect it early. There's no way that PSA will not continue to be relevant in Black men. And I totally agree with all the doctors advocating for it to start at 40. And those who are close to me, who I talk to, that's the age I recommend to them as well. Now, let me tell you something about the data that is out there. So the general population of people that develop prostate cancer, they used to be like older population, and most of the prostate cancer was like indolent. And the reason why people, like Dr. Ayodele said, and not all of them need to be treated, is like, if you look at how long it takes those indolent cancers to become metastatic and pose a threat to the life of the guy, the lifespan that he has left is not even going to accommodate that. Say the guy is 72 when he's diagnosed with an indolent prostate cancer that is confined to the prostate, is like there's nothing else showing anywhere. You don't treat it. He can be alive for another 15, 16 years for that, and that cancer not doing anything to him. And he probably will be dead within about 10, 12 years anyway. That's not the same for an indolent cancer. Let's even say it's indolent, developing in a guy who is 46. That cancer has a good enough time to become dangerous, because eventually it will metastasize. And at that time, it becomes a palliative treatment. You're not able to deliver curative therapy to widely metastatic cancer, no matter where they're coming from. Generally speaking, okay, unless some exceptions, but generally speaking, your chance is catching the cancer early at a time where you can make it go away.
Yes. The other question is DRE, is it of added value? Yes. As even Dr. Ayodele mentioned, some prostate cancers do not have elevated PSA. So I think it's important also to detect lesions by digital exam. Obviously, it's not as sensitive, but it's still of value. That is still recommended. All right, we are running out of time. As Professor Chinewondu said, this is a very heated topic. There's so much passion, so much interest on this, which is fantastic. So it's not only breast cancer and cervical cancer screening that should be done, prostate cancer screening needs to be really brought to the forefront in addition to colorectal. But
sorry,
this
Prof.
is a big discussion.
Can I make a comment, Prof? One
Yes.
comment.
Yes.
Yes,
go ahead.
just I won't waste time. Just I think I will thank Lakeshore for this meeting. And for prostate cancer, I've seen the newspapers why a prominent Nigerian is advocating for this, being a patient diagnosed with prostate cancer, being managed by Lakeshore. So this type of people will also help in this advocacy. We'll put them together, patient survivors and those patients that are willing to share their experience. He was not afraid to go on the papers and write, man, go and check yourself. And Lakeshore is was the center that he's using for treatment. So we encourage patients to form things like this, inspire people to go and check themselves. So just to put it out there, that there are patients that we can use to say it out to us for the population to be aware and use them to advocate for government to popularize this. Thank you.
Yeah, thank you. Dr. Ilebune, please take note. We know the patient in question. We should engage him. He definitely has a very big platform, so we should do this. All right, Bindia, I don't know whether you have closing comments. We've run a little bit over time. Or Oge, who is going to make the closing comments, please?
Okay, I think Dr. Iwuju was going to say a few last words, and then Bindia would close finally. Over to you, Dr. Chineye.
Thank you. I just wanted to say a big thank you to everybody for contributing. It is great to have these sort of meetings and have people engaging in these conversations. So we do plan to have more of these for Lakeshore because, you know, it's just a case of organizing them. And I think this topic was slightly off piece compared to what we normally do. So I'm really pleased that everyone has engaged and found it helpful. And we look forward to seeing you at our next meeting. Okay, so over to Bindia. Thank you.
Okay, let me see if Bindia is still here. Hi, Bindia. Are you muted?
She's muted.
Okay.
Maybe she's
not
available.
Yes. Okay. So just to say thank you really to everyone for making the time. We planned to end about 5:15, but we've overrun by another 15 minutes, but hopefully it's still been useful. It's a pleasure for us to actually have these webinars, and you know, it's amazing we're doing the 14th, and this, like Dr. Chineye has mentioned, is just slightly different. We look forward to the 15th in the last quarter of this year, and please reach out to us if you have any particular topics you might want us to consider. Thank you, and keep well, everyone. Thank you very much. Thank you also to our participants, all the specialists who have been involved and have always been involved in our tumor board. We know how busy, very busy everyone is, and we're really grateful for your commitment and your passion about cancer management, especially in Nigeria. We also want to thank SynLab for being faithful, as always, with their CPD points. Thank you to everyone else. And if I've forgotten to thank anyone, please forgive me. You're all well appreciated. Thank you.
Thank you very much. Have a good day, everybody. Yeah, at least good rest of your day.
Thank you, everyone. Thank you.
Thank you.
Thank you.
Thank you, everyone.
Bye.
Thank you, Prof.
Thank you.
Bye-bye.
Thank you,
Yeah, thank you.
everyone. Thank you.
Thank you, everyone.
Thank you.
Bye.
Bye.
Okay, good evening.
Good evening. Well, oh, hello. How are you?
Good, and you?
Very well. You made it. Thank you very much.
Yes, I just came in. I was in a loud staff for a meeting almost all day.
Oh, we'll send you the recording. There is a recording.
All right, okay. Thank you very much.
Right. Have a good evening.
Okay, bye. Same.
Bye.